I'm going to pass over to Dipti now, who's going to really dig down into the detail for you. I can't wait to hear Dipti's presentation because I haven't heard her talking for about a year or so, and I really want to know what you've achieved, Dipti. So over to me from a very excited Georgina.
Oh, thank you, Georgina. And hello, everybody. Thank you for listening to me. So my name's Dipti. I work in Croydon. I work in a deprived area with a high ethnic mix. And we have been pioneering group consultations or group clinics for some time. Next slide, please. So really just wanted to let you know what we're going to cover today, what I think was important to me when I started. Why on earth did we move to group clinics? What our experience was with group consultations, how it impacted QOF, how it impacted our patient care and how it impacted how we felt about delivering that care, and what the opportunities really were at the time that we started doing it and how we've kind of kept it going, and also how we're going to move things forward. So this tells you how we felt in our practice about diabetes. So in Croydon, particularly in North Croydon where I'm based, diabetes is huge. And I'll show you some data later on, but really we have over 1,100, coming up to 1,200 people on our diabetes register, and our list size is about 14,500. And a lot of them are from Black and ethnic minorities, with some Eastern European patients thrown in. It was really that. So it was thinking about how we would feel not so burnt out delivering diabetes care in our practice. Next slide, please. So touching on some of the things that we kind of have experienced, how our access improved, how efficiency improved, and Georgina alluded to it, something around patient outcomes, our experience of care, and being a pharmacist, I couldn't go without saying something about medicines optimization. Next slide, please. So we did on average 24 hours of diabetes, just diabetes care in the practice to manage these patients. And we whittled it down to two group clinics and one one-to-one clinic, because group clinics aren't for everybody. And that resulted in what Georgina mentioned. Our skilled nurse prescriber, actually, it released her for half a session a week, which was incredible. And it gave her back some time to skill up and do something different. It also reduced our waiting times, because we were really just booking in patients, 15-minute appointments, week after week after week. So we started in April 2018. And what we did was actually work out how we were going to deliver our group clinics. Everybody was going to be offered a group clinic at that time. And how we sort of processed it was basically they needed their tests and checks done before they came, almost like an annual review appointment. So this data showed in the first year we managed to increase our QOF processes by a significant number, 18%. And the other thing that didn't matter, which was about one-to-one clinics, was actually that DNAs really didn't matter. So, and also, you know how you get some patients who are kind of heart sync patients who spend hours with you? We found that actually some of that time was not spent doing that. In the group clinic, you're much more likely to finish on time. And I'll go into some of the reasons why. Next slide, please. So what Helen said to you at the beginning of her introduction, we found that actually patients actually did report a better understanding of their condition. For the first sort of at least 9 to 12 months of our group consultations, we found that patients actually asked the same kind of questions around what is a HbA1c. When you're running diabetes clinics for years, it's a bit galling, isn't it? Also, what we found was that actually what we'd done by having those group clinics was actually patients were collected with a similar goal, a similar common theme, and they can empathize and challenge each other far better than you and I can do, because they actually live with the condition compared to us. We also found that they struck up greater social connections. They actually wanted to talk about things that affected their diabetes in different ways. Um, so we found that actually, you know, rather than it being a traditional consultation in the way that it's hierarchical, it was much more um, you know, friendlier, I suppose, and you were equal in terms of what you did. There was greater uptake of social prescribing offers, and we actually had for a period of time um, our Asian Resource Centre and BME sort of societies come in and support us with actually working with those patients outside of the GP surgery. Um, it also gave you an opportunity to actually look at personalised support and advice for the patients, and often that kind of mirrored in a way that actually patients shared their stories, and you could draw out the threads and actually apply it to other patients in the room. Um, and they held each other to account, which was quite interesting because actually then that the onus, the expectation of care actually becomes more self-care and not didactic care. So there is a shared ownership and responsibility for doing that. And when you look at the patients and you talk to them and you hear their stories and you hear their you know, side effects, etc., it works really, really well. And they actually understand more about their diabetes, particularly when you put a person who's had a kidney transplant or a limb amputation in the same room as people who have just become diabetic or actually have really poor control, and you don't pick them, they just appear. So when we ran our group consultations, it was systematized in the sense that that was the first offer for an appointment. So actually whoever came into the clinic came into the clinic. So we didn't pick and choose. Next slide, please. So this was a biggie for me and Alison, our nurse prescriber. We actually found that, you know, we were often escalating therapy, and what we found was actually patients weren't taking it, and that's probably why their control was bad. We actually had much more meaningful conversations about medicines, the benefits, the side effects, dispelling their myths, etc. So, you know, just thinking about it, there was a broader and richer discussion about starting medication and thinking about actually, do you really want to stop this when you actually know the benefits of it? And it was really an opportunity to really go to town on shared decision making, because at the end of the day, we can prescribe things, but people don't have to take them. They might say yes to you, but actually, we really know that that isn't what happens at home. We also had the opportunity to really talk about things such as new guidelines. Actually, you know, we've moved away from diabetes, metformin and glycoside. We've gone on to SGLT2s. How do you introduce that? How do you talk about those new medicines? And also support patients in understanding actually therapies have changed and we're moving away from the old way of doing things because of these benefits. We also talk about side effects. When you talk about them in a group clinic, what happens is that basically you talk about the side effects, the benefits, the risks, the contraindications, and you talk about it once because everybody has heard it. So there's economies of scale there, and you can reinforce it with paper. The opportunities for deprescribing, when patients tell you that they're not taking X, Y, Z, are actually they come into their own. And that was one of the other things that we found quite liberating, that actually we had a better up-to-date list of what they actually took and didn't take. So deprescribing was a big thing. When they said they actually weren't going to take X, you could remove it from their drug list and know that actually they weren't taking it. So it was much more accurate. Next slide, please. So I think hopefully you can hear from my voice that actually it feels like a liberating experience of care. And actually having the time to do it properly, you spend at least an hour all together in the room. So I say at least an hour. For me, it's not an hour, but for the team, it is. For the facilitator, I spend a good 40 minutes in the room, and actually 40 minutes with 10 people feels like 40 minutes with each person individually because they're all there together. one of the other benefits that we found was actually between the team, the ownership of the board and the upskilling of the team that actually delivered that the population of metrics on the board actually became greater. So what you found was when you're running a group clinic, we ran it with a HCA and our reception manager. And what we found was actually, and they were both facilitators because we do 2 groups a week. And so what we found was that actually you the HCA actually had ownership of the board and actually felt that if they couldn't complete all the boxes, their care processes weren't up to date. So they strived to get those up and running. They also understood better what the consequences of diabetes were. So that actually really helped them a lot, and that helped their personal and professional development. And it also allowed other people to sit in. So we often have registrars and trainee doctors sit in, and they actually learn quite quickly the benefits of a particular therapeutic area, such as diabetes. Next slide, please. So I just wanted to share a little bit around our diabetes QOF data. So I kind of mapped it year on year, and what you can probably see at a glance is that actually things are no worse. But what we found is that actually for the benefits listed before, we are performing just as well as we have, and a third of our patients go through group clinics, and that is, in a way, from a workforce perspective, a really sustainable thing because actually it gives you that joy. Bearing in mind that 24-25 isn't over and we're in the last stretch, I know those results are going to improve on the end column there. But actually achieving 30%, sort of, this is sort of 3/4 of the year, if you like. What we found is that post-COVID, people were raring to come back. So you saw a huge spike in people attending group consultations because of that social isolation. But the metrics that you see, actually, we wouldn't be able to achieve in an area like we work in, okay, without that systematic approach to care processes, the results board, but also the economies of scale that we've driven. So just thinking about that and leaving you with that. Next slide, please. So really thinking about opportunities. So we've extended our group consultation approach, and one of our newer nurses has actually adopted asthma. And the modality for the group consultation is actually virtual, because most people probably acknowledge that people with asthma, because it's such a transient kind of hiatus of a condition, actually people don't always attend in person, and there's a lot of DNAs. By running the video group clinics, people could attend anywhere. And what we found is that actually she's really enjoyed it, and it's really given her a sense of achievement, actually spending that time. So I think, Georgina, you're right in saying that actually nurses really value that. But if I had to say to you what are my top 2 things why I'd want to do this and continue doing it, because we haven't stopped, it is really to improve efficiency, okay, and upskill people, but also it's reducing burnout, because actually, if you think about it, with a caseload of nearly 1,200 people with diabetes, saying the same thing again and again is really difficult, particularly under the current climate that we're working in. But it actually does really help people understand. So we've taken people from our various teams. So we've got receptionists involved, and they've all sat in and experienced a group consultation, and also our nursing team, and also the GPs, you know, from registrar perspective. Last slide, I think. Just really, just hammering home, it's the opportunity to include other people. You can involve other clinicians from different areas, so community experts in diabetes, you can have dietitians, and you can see it's really reassuring when you actually see the patients telling each other off. And it's the opportunity to really do some quality reviews in a time efficient way. And I think that's it from me. Thank you, Georgina.
Brilliant. So we've got one question that's come up for you just before we move on to Laura, and that's, why do 60% not attend the group? Have
So
you got any
overall,
thoughts on that?
yeah, overall, it's, I guess it's time. when people are actually in a deprived area, when people actually have to take time out of work to come, it's an hour of their time. I know it's an hour of their life to make it better, but we also offer phone reviews. So some of them will take that up. But generally, our annual reviews, a lot of people will. But there's also people that can't, people with serious mental illness, people with learning difficulties. So those people would find it hard to comprehend in a group setting. So therefore, we don't particularly invite them because they need that one-on-one.
Yeah. And, I know, I mean, obviously, sometimes people do have comorbidities, don't they? And, they're complex or they're, so I guess it's not a question of, people are not choosing the group. It's more for whatever reason it makes sense to see them in a one-to-one for different reasons. Would
Yeah.
that be a fair assessment,
And
Dipti?
I think you're right, and I think it does. And I think part of it is um, if they're absolutely adamant, Georgina, and there is a few hardcore that absolutely won't, and that's okay
Yeah.
because
Yeah.
90% are fine. So it's not about one modality for everything. It's about making sure that you've got an option for what suits
Absolutely.
people.
Yeah, we've done quite a bit of research around this actually as well. And what we've found is that there's two things that massively increase the uptake and the amongst patients when it's something new for them, and they haven't experienced it before. And that's having testimonials from patients who have been and can say, I was skeptical, and then, actually I kind of, I gave it a go and I was really surprised how much I enjoyed it and all that kind of thing. And also clinicians who they know endorsing it as well and saying, we'd like you to come. So what we actually encourage people to do now is to do a little video, say, it would be, hi, I'm Dipti and I want you to come to my group clinic, blah, blah, this is how it works. And then send that to people in a text, a little link to that YouTube video or something, and that works really, really well and increases the uptake. So there's little tricks and tips that you can use as well. There's a couple of other questions that have been posted. I'm going to leave those till after Laura from a time point of view. So Laura, let's go over to you because you may actually answer those questions yourself as you're talking as well.
I'll have a good try. So hello everyone. So I'm Laura. I'm a nurse practitioner down in primary care down in the southeast, and I'm just going to talk through our story really of how we've developed groups. So Dipti's really covered a huge amount of information about the data and how staff feel about it, but actually it can be quite scary initiating this. So when I was preparing this slide, I was actually really surprised that we only started in 2018. Because I'm a trainer with ELC and I've been telling people we've been doing it for 5 or 6 years. It feels like we've been doing it almost forever, really. So our GP partner met Georgina at Best Practice a number of years ago. He'd already heard about groups and we've been talking about it, but now he had some information about how they can be run. So it took a little bit of time to get the funding together. So we didn't manage to get the training until 2019. And to get the funding, we had to have a number of surgeries. So there were 4 surgeries in total that met together all in a room. And Georgina and the team came down, did all the training. And that's when it was face-to-face all in a day. So it was a lot of information to take on. But there were masses of resources, which are all in the support pack now as well if you do the training. So we did our training and we followed everything to the letter. So the big selling thing that Georgina kept saying was, you've got to set the first date. And we did. And it was quite terrifying, really. We set our date for the 28th of June and we had our first diabetic clinic. We didn't cherry pick any of the patients. We did exclude some people. This was going to be the new thing. We wanted to follow it to the T and we wanted it to work. So there were some people that maybe had very complex diabetes or other problems. So for that first group, there were a number of people we didn't invite, but it really was anyone that needed an invite and a review in that month. So we did our first clinic. We did overrun. We had our session planner, but we didn't really follow it properly. There were a couple of teething problems, but it was a huge success and patients really enjoyed it. We had a great attendance. And from thereafter, we've always used the session planner and we're constantly tweaking our processes. And there can be real light bulb moments where you think, actually, why are we doing it this way when we can save time and energy doing something different? They're really successful. I was the only one running them, but I really enjoyed them. So as Dipti said and Georgina said, for all the positive reasons that we've already covered, they're really enjoyable. You're in a partnership with a patient. Patients always call me by my first name, so they haven't got a hierarchy. We discuss things really openly. Sometimes I can sit back and actually not get involved in the discussion because the patients are answering the questions between them and problem solving themselves. So they're doing a lot of work for us. To save a bit of time, our facilitators will jot down bullet point all the discussion, so I don't have to remember what to document about the discussion. I'm only thinking about the outcomes of the one-to-one, which are always car parked. So then we launched a second group because I was really enjoying them and it was so much better than doing them back to back, one after the other. Someone asked about the number of people we invite, and for our diabetes groups, we've actually got in the habit of inviting at least 12 people because we know there will be a DNA rate. So if a couple of people don't join for their clinic, you haven't lost anything. I'm still busy. I'm still seeing 10 people. And as we've moved down the time and there's more people doing it, the clinicians doing groups also have other audit work and things to do. So if for some reason there is bad turnout on a particular day, there's always other admin work we can be doing. We've got our projects set up that we're running. So in 2023, type 2 groups were taking a lot of my time up because I was running 2 a week and I had all the other stuff to do. So our paramedic with an interest in diabetes was trained up and started running a group. So we had 1 each, which gave people flexibility. We had an early morning one and a late morning one, and we're still tweaking the times to this day. 2023, our pharmacist came back from maternity leave. She'd been wanting to do hypertension groups for a while. She was horrified in her first few weeks coming back from maternity leave. She was doing back-to-back hypertension reviews and saying the same thing over and over again. And we very quickly got the hypertension group launched. Now, we don't need to overbook that one. It's probably our best attended group, and it's one of our best time savings as well. Really, really well attended, and we're going to launch another one in the new QOF year. So we're going to have a morning one, and we're looking about whether we have one run via Teams. Then we got into November. So 2023, I was really conscious of how we could improve our COPD reviews. They're a little bit hard to get people to attend them in this area. We've got a group of patients that might travel a lot. We've got some retirees that have other things they want to do, and trying to get people in was quite difficult. So we decided we were going to completely rehash it. We have a form that they can fill out in advance. We can get all the data in advance, and we launched COPD groups. We made a number of mistakes. So again, trying things out. We did it off-site because currently our room is upstairs. So we knew this was going to make it difficult for people to attend groups. And it was one of the reasons we hadn't launched our COPD group earlier. So we hired the town hall. We had back-to-back groups. We thought these people would want a letter. We made this assumption, which was silly. So we didn't have the usual IT tech that they could easily cancel and rebook. So again, using our session planner and improvement planner, we constantly reviewed this, and now we're doing groups in the building, and next year we're going to actually start them in the summer. We've renamed them, so it's your winter planning appointment rather than a COPD review. It means more to patients. But we got loads done. We did back-to-back for a couple of weeks and saw majority of our patients in that time. So then moving on, our new patients with our patients with newly diagnosed type 2 diabetes, that can be really time consuming for a clinician. So you've got all the education, you've got the QOF, you've got all the referrals, but also you're seeing patient one-to-one and then asking them to go into a group. So we launched our groups for newly diagnosed type 2 diabetics. So it's still done in the group concept. I know my clinical agenda. I know what I'm going to want to cover, and usually it comes up with the patients that they're the questions they want to ask. But we're quite open as well and say, actually, I'd like to talk about statins, or I'd like to talk about education referrals or retinal screening. Are you happy for me to talk about this? We give slightly longer. Once they've come to that first group, thereafter all their appointments are in groups. There's no special sorting out of patients. Although interestingly, we were teaching this last week, and someone said they were running groups specifically for women and specifically for men to talk about sexual dysfunction, and maybe they might be a bit more open there. So there are elements of you can change the group setup as you go on. The new type 2 group has been really, really successful. We get a really good attendance, and they come back into groups without thinking about needing a one-to-one. We then, one of our GPs trained in as a clinician, and we launched our menopause groups. Again, lots of tweaks, and there's some really good ideas I've seen coming up in the chat about how you can run those. And coming up to date now, we've had some new facilitators join the group. So our recall team that are sending out the invites are also our facilitators. We work really closely with them. One of the big learning points was we have to listen to your facilitator. There's got to be equality. You can get very involved in a great discussion. Sometimes you could really go off track and talk for ages. People need to know they're going to finish on time. So our facilitators have done the training, and now we've got quite a team. So if someone's sick, someone can step in quite quickly. Last year, we were also involved in doing some filming to promote group clinics, and we use that on our website. So there's lots and lots of information on our website. As Dipti said, it's great for time saving. It's great for clinician morale. It's so much more enjoyable. You have some really interesting discussions. Don't really have anyone concerned about consent. We might have one or two. Sometimes we have people say, I don't mind sharing my details, but I don't want my name on there, please. And that's fine. We still have the same discussion, but they might not want their name up on the board.
Laura,
yes.
Laura, you asked for a time prompt, so I'm just
Thank
letting
you.
you know. About a minute, please.
Thank you. So I'm going to say we overbook, we uncover misconceptions, patients challenge each other. We're using patient activation scores now, so we're going to do a study in does it help patients become more activated. Patients, we always encourage a group versus a one-to-one. Next slide, please. Or last slide. So where are we going through? You can see there's a range of clinicians that do groups. So anyone can do it, and the subjects that can be used for, like health checks and things. I'm picking up great ideas as well. Next slide, please. So where we got to 2025. This is our waiting room at the moment. This was the photo yesterday. Our upstairs room is not great for people with COPD. It rules out all our wheelchair users and disability users. So we're building a new room, and the aim is we're going to be using it by the summer 8 groups a week, and by the end of the year we want a group in every morning and every afternoon. So we're really trying to roll this out and increase the numbers, and I've just seen the time, so I better finish there, Helen. Hopefully I've covered everything for you.
Thank you, Laura. Well done.
So just there haven't been many questions in the chat yet, but one of the questions was, or for kind of a little bit of clarification, was that Dipti, you mentioned that it can help with economies of scale, and I think Laura's clearly shown that economies of scale are also happening in her practice. But that you mentioned costs incurred setting up and running group clinics, Laura. I thought that might be mainly training, but I don't know if there were other things. Obviously now you're looking at doing some changes to the estate, which you've got a cost attached. Was there any other bits around cost early on in the early days that you had to look at?
I think we just decided that we really wanted this to work. So if you want it to work, you need to invest time in your staff. We ran group clinics about group clinics for the whole staff, so everyone understood it. Our new starters come and sit in a group. So anyone in the building, if you talk about group, understands how it works, but also allow a lot more time in the beginning. You will save time down the end, but if you've got a stressed clinician because they've done a group and now they're thinking about documenting or preparing, I think in the first few weeks, really really allow that clinician and that facilitator the time they need to hone their skills, be reassured, because they will get much faster. And I would say our group discussion is now probably 80% of my time. By the time I do the one-to-one, the patients have decided what they want to do. There's far less decision, but really invest that time and energy in the beginning.
Yeah, absolutely. Dipti, anything to add to that in terms of costs and that kind of thing?
Completely agree with Laura. It is about investment in your team. But the other thing is, I mean, it's cost efficient. So actually, you know, when you're actually thinking about from a practice manager business perspective, you know, your 20 minutes, 15 minutes per appointment is, you know, easily done in 45 if you group it up. And if you add in, say, half an hour to document, then you're easily time up. And also the DNAs don't matter so much. So therefore, people are not sitting, I'm not sitting twiddling my thumbs. I think one of the questions was around QOF, Georgina, if I may just butt in on that one. So there's two aspects to group clinics. One is making sure that everyone has their tests and checks done, which is quite a lot of the QOF tick box and what processes you have for that. And then the second part is actually treating people to target. And that's where the group clinics come into their own, because sometimes it's difficult to convince people to actually take drug X, drug Y, etc. And so having that discussion in a group setting with other people that are already on it or etc. really helps you to actually sell that medicine or that program to, you know, low calorie diet remission program. If one person's tried it in the group, it's an easier sell. You find that actually everyone wants it then, even if they're not eligible. So it's quite funny, etc.
A few people have been asking about training and that kind of thing. And one of the questions is, do you need to have training to do this? Just wondering what you guys think about that.
So Laura, do you want to go first?
I was just going to say it really worked, yes, because you got all the materials. The ELC has done all the work. You just pick up a model and run with it.
Yeah, I think it does help to have training. We had ours in 2016. It was a gestational elephant. It took us 2 years to actually up and run because we were umming and ahhing. But actually, the training and, you know, a little bit of hand holding sometimes really does help, because as Laura said, it's really daunting initially. But when you start, and I think Laura, you'll agree, I picked my best patients, the ones that I knew, the ones who weren't going to have a go at me. So I picked them because actually I wanted to be sure that the processes we put in place were good and it would all work out. So that way you get the confidence behind you to actually carry on.
Absolutely. And the other thing about it is that, you know, I think don't just to say that there's a lot of, you know, fiddly bits around the admin, which if you had to do those yourself without any support or templates and that kind of thing, you know, that used to be the big barrier, didn't it? Before, you know, if you think Dipti to back to when you got trained, that was the big barrier. Now we've got guides to using System 1, you know, EMIS, etc. It just, you know, life is just a lot easier and we're on top of all of that. So people are posting in the chat if they're interested. We've got to kind of draw things to a close. If I don't think that there's any more questions in the chat, Helen, have you picked up on anything? I see that we've got somebody with their hand up, but would you mind posting in the chat if possible? If you're not able to post, maybe let us know. I think that's Georgina, you just posted now.
There's one question. Is there any guidance relating to CQC compliance for such clinics?
Okay. So CQC, no, but NHS England has kind of guidance around managing the clinical risks in group clinics. We will send you links after the webinar to some. There's a site on Future NHS where you can go and have a look at that. That's obviously all covered in training as well. So it's not so much CQC. CQC likes group clinics and they're often complement practices that have set up group clinics. I don't know whether Dipti or Laura have got anything that you can share on how CQC's responded to your group clinics.
So I did a piece of work with Northumbria and Yorkshire CQC, and they were really interested in group clinics and that modality to actually have shared decision making and care within the practice, and they were really complementary. So they are actually looking for innovative ways in which you can actually support your patients and they can support themselves. And there's an awful lot that goes on, doesn't there, in a group clinic. In that 1 hour, so much gets covered that you can't cover in a one-to-one.
Yeah, absolutely. How about you, Laura? Surely they must have noticed the building works CQC.
I think everyone's noticed building work. I think it really supports shared decision making, and if you look through the CQC requirements, you can add, you can pin group clinics on so many of the requirements that they want. It really is easier.
Yeah, absolutely. Brilliant. So I'm going to hand back to Helen to finish off the session.